Hello colleagues. So today we will be discussing a case of a 60 years old female who presented with fatigue for the past 3 weeks. Her clinical examination was unremarkable. So this is the ECG which is recorded now, and now what we see on the ECG, first of all we have to see what is the sinus node function like and the AV node. So let's go and check both of these. So let's start from here. So let's take into account lead 1. So we can see that there are few P waves here, 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 and obviously somewhere here, here, and here as well. So now what's interesting in this ECG is, so what do you think? Is this a normal sinus rhythm or something else is going on? So for a normal sinus rhythm, what we know is that the P is the driver of the circuit. So for that, the P wave has to come early than the QRS. But now what's happening over here is that there seems to be no relation between the P and the QRS. So is it AV block or is it sinus node dysfunction? Now this is a very important concept that needs to be brought into mind when considering the diagnosis, as definitely the management might vary depending upon the diagnosis. So this sometimes baffles some of the clinicians who are not used to seeing these types of ECGs. So for that purpose, let me make now the concept clear in your minds regarding the difference between the sinus node dysfunction and the AV blocks on the ECG. So now we can see that the sinus activity is present on the ECG, but there is sometimes some kind of varying R to P intervals, like this is R, this is P, this is R, this is P. Now look at this is R, this is P. So there is no fixed pattern. So now the question arises, what is the driver of this circuit? Is this the V or is this the P? So how will we decide? So now let's go and so these are the P waves which I have discussed earlier, and now I have marked them for you as well. So now coming back to the main focus, which is the driver. So for that we need to see some things. First of all, I have zoomed in lead V2 and lead V3. So now we can clearly see that there are P waves over here, here, and there's also QRS as well in all the three complexes. So this means that we have one-to-one relation. Now the important thing to understand is, in a sinus rhythm the P wave has to come early, but here it is coming after the QRS, although it is still coming. So what does this mean? So for that we need to do some measurements of the intervals, which I have done it for you. Let's go and see that. So these are the P to P intervals and these are the R to R interval. So now the the P to P interval is 55 beats per minute, or atrial rate is 55 beats per minute. So this means the atria is not firing quite good. This appears to be some kind of pathology going on. That's what caused the sinus rate to slow down. In normal healthy hearts, it should be around more than 60 beats per minute. So this is marginally low, but definitely anything less than 60 needs to be looked for any pathological causes. And now let's come to the R to R interval. So the R to R interval was measured around 60 beats per minute. So this means the ventricular rate were faster as compared to the atrial rate. So what does this mean? This means that the atrial rate has no influence on the ventricular rate, and that's what we initially thought when we saw the ECG. So although this was a marginally low difference, but still it was significant enough to suggest that the ventricular rate is not being driven by the atrial rate. So the interval measurements of the interval are very important in this case. So even a single small box of 40 millisecond can make a huge difference in making the diagnosis. So be careful in doing the measurements, especially in the case of bradyarrhythmia, when you need to identify whether it's a sinus node disease or an AV block. So it cannot be an AV block because for an AV block, the sinus rate should be faster, and then there should be a kind of non-conduction or slow conduction or intermittent conduction down the AV node. But in this case, the sinus rate is slow enough that it cannot influence the faster rate downwards of the ventricle. So, although the sinus node is considered the pacemaker of the heart, but in this case it has slowed down, and as a result of that, the ventricular rate has got the influence on the ventricle was kind of diminished, and it was not present. That's why they started firing on their own. So this was basically a case of sinus node dysfunction. Okay, so let's discuss some anatomy and we'll study some clinical aspects of this as well, how to manage this patient. So first of all, anatomy. So the sinus node is an epicardial structure located at the junction of the right atrium and the superior vena cava. So it's not a discrete structure, it's a kind of a meshwork or network of so many fibers that constitute a sinus node. And it is supplied by the sinus nodal artery, and which arises from the right coronary artery in around more than 50% of the patients, and in the circumflex 40 to 45% of the individuals. The sinus node is innervated by both the sympathetic as well as parasympathetic nerves. Now let's study some pearls in managing the patient of sinus node dysfunction. First of all, in sinus node dysfunction, we need to see whether there is an established minimum heart rate in the literature or not. In the literature, there is no minimum heart rate or pauses which suggests that this is a cutoff for the permanent pacing. However, we have a cutoff for the diseased sinus node which is less than 60 beats per minute, but there is no cutoff for the permanent pacing. What is important in this case is, in the case of sinus node dysfunction, we need to correlate the symptoms of the patients with the scenario. So, if the patient is having sinus node dysfunction, he is having symptoms, then he should be considered for permanent pacing, and that is very important. In this case, in the case of sinus node dysfunction, we always need to correlate the symptoms for the permanent pacemaker decision. Okay. Now, asymptomatic bradycardia, although it is not commonly seen, but definitely this needs some workup as well, and we need to follow these patients as well in the future because they can become symptomatic at any time. We cannot leave them on their own. We need to have a closer follow-up on these patients. And asymptomatic bradycardia can become sometimes symptomatic intermittent in between as well. So we need to have a good eye on these patients. In clinical practice, we can sometimes see those patients like healthy patients, like athletes who have a physiological bradycardia. This means that their resting sinus node might be around less than 40 beats per minute. They will be perfectly healthy and they are incidentally found to have a decreased sinus node rate. But this does not mean that he will or that patient will require pacing. Okay. In these types of cases who have physiological bradycardia because of the influence of the autonomic system on the sinus node, like in the example of athletes, we will not do anything. So in the case of these patients, there is no need of pacing. But definitely in those patients who are at the opposite end of the spectrum, they will definitely need a pacemaker as early as possible because the symptoms will not go away if you do not put in a pacemaker. Now, let's revise some guidelines in the management of sinus node dysfunction. First of all, sinus node dysfunction patients, in those patients whose symptoms can be clearly attributed to the episode of bradyarrhythmia, there is no doubt about it that he needs pacemaker. We always have to put in a pacemaker. This is a class 1 indication. Okay, so always remember S for sinus node and S for symptoms. This will make your life easier. Any patients who's having symptoms and sinus node will definitely need pacemaker unless there is a reversible cause found. Second point is pacing is indicated in symptomatic patients who are having tachybrady syndrome. Now, this is one of the important type of sinus node dysfunction because sometimes this might make the clinician confused whether this patient is having tachyarrhythmia or a bradyarrhythmia. In these types of patient, you need to clearly identify the diagnosis of bradytachycardia syndrome. In these patients, sometimes they will have bradyarrhythmias and tachyarrhythmias in between. When they suddenly terminate, they go into very long pauses. So this means that you should always be looking in the management of sinus node disease in such types of patient. In these types of patients, they usually have a bad prognosis and they have a worst outcome. They need permanent pacemaker along with the management of tachyarrhythmia. Sometimes you also find those patients who do not have symptoms at rest, but when they exercise, they have the symptoms, although they are having sinus node disease. So these patients are called patients having chronotropic incompetence. In these types of patients, when you clearly correlate the symptoms which appear when we ask them to exercise because of chronotropic incompetence, they will be developing symptoms. And when you correlate these symptoms with this chronotropic incompetence, these types of patient also require permanent pacing. Now, one last final point, whenever deciding for a permanent pacemaker in a sinus node dysfunction, the mode that should be selected should be a triple D. This means there should be both the atria and the ventricular lead should be placed in the patient. Even he is having a sinus node disease and his AV node is fine. But the studies have suggested that in the long term, these types of patient might also develop AV node in 1 to 2% of the patient. So they will need to be having double chamber or dual chamber pacemaker. The guidelines suggest that always dual chamber pacemaker are preferred even in isolated sinus node dysfunction. The other option will be a single chamber in the atria that is called an AAIR pacemaker. So this was all for today. Thank you for your listening.